Welcome, everybody. We are here today during our EAU meeting in Paris in this April 24. And here we are at the EAU TV to talk about adjuvant immunotherapy in high-risk renal cell carcinoma. Today, we are in the company of three of my colleagues. One is Jens Bedke. He is a urologic oncology, and he works in Stuttgart, Germany. My other colleague is Umberto Capitanio. He's also a urologist, and he works in San Raffaele in Milan. And my other colleague is a nurse consultant. He's Mr. Alcorn, and he works in Leeds in England. Welcome, everybody, and we are happy to have you for the discussion.
Yeah, thank you.
So for the next 20-25 minutes, we will discuss some of the key items about adjuvant treatment for high-risk kidney cancer after surgery, and what are the most important criteria to select patients in order to decide to give the treatment. So please, Jens, go ahead with your presentation first, and then we talk about it.
Yeah, thanks, Carmen. So I think the adjuvant treatment in RCC, it's a very, very important topic, and we all know that we have an immune checkpoint inhibitor which is approved, and that these are the results of the Keynote 564 trials. But it's a difficult field because we have a lot of other trials who were negative, and also going back to the TKI era, we know that there were very mixed results, which were mainly negative. So I think first of all, let's have a look at my disclosures. Let's have a look at the positive trial, the Keynote 564, which is a phase 3 trial of adjuvant pembrolizumab in renal cell carcinoma of intermediate high risk and M1 NED patients. I will go into detail what this actually means. And in Keynote 564, patients were randomized 1-to-1 to receive pembrolizumab every 3 weeks, 200 milligrams for up to 1 year, or placebo. And the primary endpoint was disease-free survival as assessed by investigator. I think you're quite aware that this trial met its positive endpoint. So who was at risk of disease, who is at risk of death? And these are the pre-specified disease risk categories which patients had to meet to be included in Keynote 564 and to be treated. And this trial defined 3 risk groups, ambulatory risk groups: the intermediate high risk group, T1, grade 4 or sarcomatoid patients, T3, any grade, all node negative. Then we have the high risk group of T4, or the patients who were node positive. And last but not least, the third risk group was the M1 NED risk group. That means that patients who had metastasectomy with the resection of oligometastatic disease within the first year after surgery or at the same time of surgery. So these are the 3 risk groups. What are the baseline characteristics? In total, everything was well balanced. More than 900 patients were randomized. We had the majority of the patients, 86%, were in the intermediate and high risk group. That's T3 or T2, G4 sarcomatoid features. And if we have a look at the PDL status, nearly 3/4 of the patients had a PDL1 positive expression. So this is the result of the primary endpoint, the significant improvement of the disease-free survival. On the left side, the results from the primary readout, and then we had the first follow-up after median follow-up of 30 months, and we see that there's first a consistency, that the curve stays stable, and that they had an improvement of nearly 37% in disease-free survival by this adjuvant treatment. If we move on and split this up into the different risk groups, and there might be the question, is that influenced by patients who have a higher risk and a higher risk group, that the M1 NED, or the high-risk patients of node positive disease, T4, we observe that the disease-free survival was improved in every risk group, irrespective of the individual risk constellation. So what about the other side of the coin? I talked about the efficacy and the improvement of disease-free survival. And we know that if you do an active medical treatment, an active systemic treatment, even if it's based on an IO component, that we have side effects. And the first message is that the side effects, yes, they are present. But if you compare that to the primary analysis and then to the updated analysis, and we also have a third report having presented at ASCO GU this year, we have a consistency. So there is no accumulation over the time for the side effects. In generally, 18% of the patients who received pembrolizumab had a discontinuation. and we had observed grade 3, 4 immune-mediated adverse events in 9-10% of the patients. On the other hand, if you have a look at the all-cause adverse events, these also happen in the placebo group. For me personally, this is reflective of a more or less psychological burden which a patient has than he has a renal cell carcinoma as a primary diagnosis. So what about if we make a deep dive into the immune-mediated side effects? And of course, we are aware that we used an immune checkpoint inhibitor, the PD-1 antibody, the pembrolizumab, and that this provokes immune-mediated adverse events. It's a rare events which were observed within the trial. But on the other hand, there were some patients who had a myocarditis and encephalitis, and I think it's an interesting topic to talk about. Even if it's very rare, it occurs because it has an impact on patients and their subsequent life, even if they are, well, in a situation that they are potentially cured by the surgery alone. So if we go to this risk-benefit balance, and this is the question, we have the improvement of efficacy, they have the adverse events, and they have the balance. So first of all, I think we try to avoid metastatic disease with the adjuvant therapy, and we had no evidence until recently that this early treatment is useful and is justified compared to the deferred treatment. And shall we treat the patient, and this is one of the questions, if they relapse, if they have metastatic disease, or is early treatment and over-treatment? All these questions which we have maybe a little bit answered by the latest update which we received from ASCO-GU, because I have been talking about the disease-free survival improvement, but we haven't talked about overall survival. We got from the primary analysis an overall survival signal. This year's ASCO-GU meeting, we got the updated results for the overall survival, which was a secondary endpoint, and the secondary endpoint was significantly met. And we have a hazard ratio of 0.62. That means a 38% improvement of death by this data, by the adjuvant treatment of pembrolizumab. And if you look into the subgroups, once again, I would like to sharpen a little bit your eyes to the individual risk groups. And we observe that everything is more on the left side, so that they have the benefit across all risk groups for the overall survival improvement, for the M1 NED group, for the intermediate high risk, but also for the high risk group. And if we look at the PD-L1 status or the sarcomatoid features, also patients who are PD-L1 negative, patients who have no sarcomatoid features had a benefit in the overall survival improvement. And with this data from ASCO-GU, we also got an update for the disease-free survival with a longer follow-up. And we clearly observed that the curve stays separated and that we have a separation at the 48-month time point after 4 years of follow-up of 64% who were disease-free compared to 56% in the placebo group. So again, two sides of the coin. I think we have the improvement, the delta of more than 8-9% between the treatment and the placebo, 64% after 4 years, the disease-free survival. I think it's a very good number. On the other hand, we also have 56% of patients who do not relapse, who have been cured by surgery alone, which we should not forget. So to conclude all this, and just to give you an overview of the data for the pembrolizumab derived from the Keynote 564, we should never forget that the aim of adjuvant therapy is to reduce the risk of recurrence and to prolong overall survival. We have no benefit of the adjuvant TKIs, which I haven't talked about in detail, and that Keynote 564 was and is the first trial of a PD-1 antibody who demonstrated to prolong disease-free survival, and now with the major overall survival also demonstrated to prolong overall survival. So I thank you for the introduction and hand back to Professor Mir.
Thank you, Jens. Great presentation. And I would like to, for the next 10 minutes, 10-15 minutes, to dive a little bit more into the details on the real practice and how do we apply all these results to real life. And so we know that for optimal adjuvant treatment, we want something that is cheap, that is well tolerated by the patient, and it works in microscopic disease. This is why we're discussing all this stuff, and that improves survival. Okay, that would be the optimal treatment. And we have had, as you mentioned, several adjuvant TKI trials that did not show an overall survival. Only one of them actually proved a disease-free survival, a benefit. And we have other adjuvant IO trials that so far have not shown any advantage. Only the one we are talking about, Keynote 564, has shown the overall survival advantage. And as I told you, for me, I would take into consideration 4 items when I have to decide, from my perspective, quality of life would be very interesting, cost, toxicity, and obviously survival. So the efficacy of the treatment in order to decide if it's worth or not. So let's discuss a little bit more on that. As you have mentioned, we could have actually 3 clinical scenarios where we could apply the drug. These are more or less the scenarios that I thought of. And I would like you to discuss in each of them where would you give the treatment or not, depending on how much benefit you would get out of it. So one scenario would be an intermediate high risk that, as you mentioned, it represents mostly 80% of the patients that were included in the trial. So let's say we have a 54-year-old female with mild rheumatoid arthritis that has a T2 8 centimeters right renal mass that gets an nephrectomy, and finally it's a T3 G3, so high grade, and no nodes, but sarcomatoid features are present. So if we could do the calculations for the risk of recurrence, that would be around 80% for this patient. Jens, would you advise to go for a treatment on this lady? Sorry.
Well, I think it's an excellent case you prepared, and I think what are individual risk features for me here in this patient? So first, it's a sarcomatoid feature. So I think this is an adverse prognostic factor, and it's a grading degree, grade 3. And maybe it's not an adverse prognostic factor, but it's a young lady, 54, so it's a young patient. And I definitely would counsel her, and now as we have the overall survival data, recommend her an adjuvant treatment with pembrolizumab. But of course, I would also tell her, well, we have the chance of already being cured, and we have the risk of overtreatment, but taking together all these facts we currently have, yes, I think it's a candidate to perform 1 year of pembrolizumab.
Mm-hmm. How about you, Umberto? What do you think from that case?
Thank you, Carme. I partially agree with Jens due to the fact that there are 2 additional points that should be discussed a little bit. The first one is that 80% of patients will not recur in the first 5 years, and this patient has mild rheumatoid arthritis. And there is a high probability that an adjuvant immunotherapy will worsen a little bit the chronic disease, with no benefit probably in the early postoperative period receiving an adjuvant setting. So probably I agree with Jens that this should be discussed in a multidisciplinary panel, that immunotherapy is an option. However, the details regarding especially the chronic diseases here can make a difference in terms of probably also to observe a little bit during the follow-up if the patient is going to recur or not.
That's good. How about you? We move to another scenario, like let's have a 69-year-old guy that has coronary disease. He had stents inserted. He has a T3 7 centimeters left renal mass that becomes a PT2 high grade, but N+ in this case. So we look at our nomograms for prediction of recurrence. That is it's going to be free of disease, 32% chance of being free of disease. What would we do in this case? Jens?
Yeah, I think the nomograms are quite helpful, and we see the difference here that they have a 5-year overall survival estimated by the UISS at 32% level. On the other hand, I think it's time for an update of these calculators, given of the new data, the new trials, so that we should not only rely on the historical data. This also brings us to the topic, do we need a biomarker selection here,
right?
Not only TNM selection. But for this case, I mean, he's not positive, and this is reflected by the calculators, have a high risk of recurrence. So my first step would be to do a re-imaging at least 10 to 12 weeks after the initial surgery, just to be sure that this patient has not developed new node positive disease or distant metastatic disease, so that we are really in this M0 situation and the classical adjuvant situation. And yes, I mean, if this is the case, I will recommend, I would recommend him, just looking him or her, I would recommend him, but it's it's a man in this
Would
case.
would you be worried for the cardiac disease at all?
Well, not really. I would be worried if this would have been a TKI, to be honest,
Okay.
because the arterial hypertension as an adverse event. We know the coronary artery disease. We know that myocarditis could be one
Right.
immune-related adverse event. But it's really rare. And I think if you have a close look at him, and we have laboratory values to measure that, the heart insufficiency,
Okay.
the pro-BNPT, for example, if you measure that and have a close look at him, and that's fine, yeah, at the end.
How about you, Umberto? Would you advise your patient to go for treatment?
Yes, in this case, I completely agree with Jens. The nodal disease is one of the most important predictive factor, and also the restaging is a key because roughly 1/3 of the patients with nodal invasion will show very early and bad disease already in the next month after the surgery. So it's mandatory to identify patient that is going to recur in a systemic disease. In that case, probably even a combination therapy can be the case. But in the case of the restaging is completely negative, probably this is one of the ideal candidate for adjuvant therapy.
Okay, so finally, last case scenario is a patient as is 49, so quite young, no past medical history, but clinically he had a seizure diagnosis, and he had a T2 10 centimeters left renal mass with a solitary M1 in brain mets. So it's basically a PT2 with a brain met that was resected. So that would be considered an M1 NED. So the chance of recurrence, again, since their nomograms are not very accurate, is pretty similar. It's around 20% free of disease in 5 years. So what do you think, Jens? Do you give treatment?
Oh yeah, Carme, you're really challenging us with this case. I mean, it's getting more and more difficult because the patient is younger. He's 49 years old. Actually, he's fit. No prior medical history. It's a T2 tumor. And then he has one single brain met. So from the tumor characteristics, T2, that's I think it's in the intermediate high risk, very on the lower risk profile side. But on the other hand, maybe this also stresses that we should never forget to do a brain imaging, because we know that patients who present with metastatic disease have a 10-15% level of having brain mets already being present. So I think it's a rare case of the brain mets removed. But what does the brain met tell me? I think if brain metastases are present, it's a very adverse prognostic factor. So these patients do have a high risk of decreased overall survival and a very high risk of dying of their metastatic disease. So first of all, I think it's a clear case for a multidisciplinary tumor board discussion, especially with the radiation oncologists together, because we should discuss if the brain should be prophylactically irradiated in an interdisciplinary fashion. So if we need that as an adjuvant therapy, the radiotherapy here, I would be careful to go straight forward for the adjuvant pembrolizumab treatment here in the adjuvant situation, because I have a little bit of fear that we could run into the risk of undertreatment. Because we know that from the factors, brain mets, the patient has a high risk of relapse, high risk of progression of metastatic disease, and that single pembrolizumab, then a single IO PD-1 inhibitor in the area of IO TKI combinations or IO combination in the metastatic disease would be an undertreatment. Mm-hmm. So, well, maybe Umberto, you have other thoughts, so you would do the restaging a little bit more pronounced.
No, yes, I agree with you. There is also a confounding factor, an issue related to the fact that in Keynote 564, brain met was an exclusion criteria. Yes. So actually, we are not so sure that we can apply the results of the randomized clinical trial in this specific setting, because that kind of M1 NED patient actually was not included. So I agree that, again, the MDT should be considered, because in that case, also combination therapy up front could be the option, given to the fact that we have the complete data coming from the randomized clinical trial.
To
be very strict, so it's a data-free zone, because brain mets were not included in 564. I think this is an important point. Yeah. And if you have
bone mets as well.
Yeah.
They were mostly adrenal, lymph node, and lungs, probably.
On the other hand, I think if we look at the IMDC risk profile of this patient, actually, he isn't favorable. Is he intermediate here?
Yes, is an option. But I think that in this case, the real life scenario will help. I mean, all those publications where probably in that specific clinical case, immunotherapy will be used can provide, although with a lower level of evidence, but some findings suggesting if it's better to observe or a monotherapy or a combination of therapy in this specific young male case.
Jens, any comments in the usual with the synchronic diagnosis of the metastasis versus metachronic disease?
Well, I think we have the IMDC risk classification, the favorable, the intermediate, and the poorest. And we all know that for the patients who present with synchronous metastatic disease or within the first year after doing the primary surgery, that they got 1 point and that they are in the intermediate risk group. So we should not forget that these are patients who have a high risk of relapse and that they are IMDC intermediate. They are not IMDC favorable. And we know that in the IMDC intermediate risk group, and if we refer to the EAU RCC guidelines, that in the intermediate risk group, we recommend an IO-based combination therapy and not a monotherapy, which is actually a new recommendation in the favorable risk group, that the TKI monotherapy is also recommended besides of the TKIO combinations, but this patient is intermediate.
So do we wonder if there is do you wonder if there is like an under treatment with the patients and the subsequent therapies after recurrence? Because we saw that most of the treatments that the patients got at recurrence was TKI. Do you think that could have altered the results somehow?
Well,
maybe Umberto.
Yeah.
The question is great. Actually, I don't have the answer. Could be, but probably it's earlier. Also, a longer follow-up probably can answer also to this specific setting.
I mean, the question is, what do we do after if a patient relapses after having received adjuvant pembrolizumab? And I think, for me, there are 3 scenarios. So the first scenario is the patient relapses under active treatment, under pembrolizumab within the first year. And the second scenario is that the patient finishes the 12-month and has like 6 to 12-month follow-up and then develops metastatic disease. And then you always know in life something is in between. We have the third scenario that the patient finishes the 12-month and then has an early relapse. And I think when do we consider the patient to be IO refractory? Of course, I think in the first scenario, if the patient relapses under adjuvant pembrolizumab, under an active IO-based treatment, I think this is a patient who is IO refractory. So we have no data, but given that he is considered to be IO refractory, an IO combination therapy does not make sense in this patient. So it's very reasonable that this patient receives a TKI as a monotherapy in this setting. And the second scenario, if they had enough time in between, like 6, 12 months, I would consider this patient as a new onset of first-line metastatic disease, and I would treat him as if he would present with the first time of metastatic disease, and this is for an IO-based combination therapy, either TKIO or IO-IO. I mean, we can go into details for that, but this is a long discussion, I guess, yeah.
Let's move a little bit into the side effects. Yeah. Maybe our nurse consultant can tell us a little bit about it. So how do you manage the side effects? What happens when a patient has a side effect and doesn't want to go through therapy anymore? Do you push for it? Do you wait? How do you counsel your patients?
Thank you. Thank you, Carmen. I think it's quite difficult when a patient develops side effects and then presents and says,
I want to stop.
I want to start, do I carry on? Yeah. I think there's a lot of things that you have to take into account. But I think it's important to take a balanced approach, a patient-centered approach, and look at what is the overall survival for this patient. Where are they in the treatment pathway? How long have they gone down? But it's equally important to prioritise the patient's well-being, the quality of life. What are their priorities in life? But also look at their, if you like, their risk profile. Are they a person who would like to take risks or not? So it is quite difficult, and I think it's a team approach as well with the patient, not just.
Would also depend on the scenario, probably. If it's a high risk, a real high risk scenario, we push for it.
Yeah.
Instead, if like it's in the intermediate side, we might.
And that's where the team approach comes in saying, actually, we would prefer to keep this patient on, even though the patient might prefer to come off.
Right.
But you have to explain these things to the patient and educate the patient so that they understand. And if you do that, then they are likely to continue and trust. And if you make it a team approach and with open and honest communication with them, then I think they're likely to carry on.
Okay. How about the issues with the cost effectiveness? Do you have any issues in the UK with the social toxicity, like cost and the side effects associated with missing work or all this stuff? How do you manage it?
I think that affects everyone, not just the UK.
Yeah.
And I think you have to look at the different healthcare systems in how they manage that. I think, yes, there is obviously the cost, not the cost to the healthcare system, but also the cost to the patient, whether that is financial or otherwise. But it is looking at, is a drug cost effective for the patient to stay on as well, and how the system supports that. In the UK, we're very lucky in that we have things like NICE and the Drugs Fund that will fund these drugs. But for the patient, you have to look much more socially. Is it helping with the cost of travelling, cost of childcare, especially in the young patients and those sorts of things to keep them on. As for the cost effectiveness of the treatment, I wouldn't be able to answer that. I'm not a financial expert in it, but I do know that studies Lay in 2023 actually reported that in renal cell cancer that pembrolizumab is cost effective.
What do you think, Jans? Have you looked into the cost effectiveness of the treatment at all?
Well, I think it's always a question of the health insurance system and of the respective country where you are. So the data here is from the US. And we know that they have another healthcare system, which is very expensive, that we heard from Jason from the UK perspective. And I love that your approach in your country, that you really try to mirror down what is the cost effectiveness based on the actual costs, on the life expectancy, putting all together, and then at the end going for a result and a recommendation. And if you compare that, I think for Italy, for Spain, for Germany, we have different reimbursements. On the other hand, it's an important topic to talk about, and maybe it's also a question which is the respective price for each country. So it's not the same, and I think we have to adjust. But it's not only that the medical costs, it's also, I think, the psychological cost, the cost of working life costs, the everything in the social system of each respective country. So if we have a younger patient who's able to go back to work and can pay his taxes, I think this is a backflow of money again, which should be calculated in all these calculations.
Right, quite difficult.
Yeah.
How about in Italy? Any issues with the cost of this therapy?
Yeah, sure. I mean, for example, due to the fact that the only PFS was positive until January, only one of the category was covered by the health system. That was the M1 NED cohort.
Okay.
Yeah, exactly. Obviously, now with the OS benefit, probably will change something. And also all the papers that analyze the cost effectiveness actually are based only on the PFS results. So now probably are papers that should be redone according also to longer follow-ups, additional costs, also the advanced events that are also those can drive additional costs, especially for chronic diseases.
Thank you very much. I think we discussed more or less the hot topics on this area of disease. And I thank you a lot for your points of view and your insight on this. And we hope it's useful for our audience. And we hope to see you next year. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.